Hello, this is Shoemaker, and I'm here with a special announcement for you today. I'm going to be talking with Amy LaHood, who is a family practice physician. She's worked with our residents in the past, and she's been on the governor's task force for prevention of prescription drug abuse. Did I get that right?
Yeah.
Okay. So today we're going to talk to you about a couple of things. The first is the new St. Vincent Medical Group narcotic prescribing policy, and then also Amy's going to talk about the education and support we're going to give you to work through the new policy. So, Amy, why is prescription opioid abuse a problem in the state of Indiana?
Well, a lot's happened over the past 15, 20 years, and a lot of it physicians had no control over. We were kind of given some mandates to accelerate our, questioning of patients' pain. We've been graded on how well we treat pain, and then we were misled by the pharmaceutical companies. So when you take all that, in addition to an aging population who has an increasing burden of pain, we started prescribing opioids at about 400 times the level over a 10-year period. So for a long time, most folks believed that we were helping people. Most well-intentioned doctors were told there is no ceiling, that opioids are safe. And fast forward to the past few years, we now know that prescription drugs are causing more deaths in the state of Indiana than car accidents. We know that there is now a problem with heroin, which a lot of people are attributing to the starting of prescription drugs. So there's a lot of things that have happened that have led to this. Some of the things that have given us better guidance. The CDC recently released in March a new policy to give physicians more guidance with prescribing opioids. Several professional societies have done the same thing, and I think that leaves us physicians in a little bit of a lurch because it kind of turns upside down everything we've known about treating pain for the past 10 years. So it's a challenge. A couple of the things that we're focusing a lot on, and several of these policies focus on, is we know dose matters. So we know that the dose of the opioid really is related to the level of risk. So the CDC has said that the level which they recommend is 90 milligrams of morphine equivalent daily, and they've also really highlighted the risk of methadone. Methadone is only 2% of opioid prescribing, yet it's in the toxicology of 30% of all the overdose deaths in the country. So that's a really high-risk drug, and we're really trying to work to be safer on those two fronts.
Thank you. And I think that's a great summary of what's driven us to coming up with a policy for narcotic prescribing within the entire medical group. We've worked with our regional medical directors, we've worked with Amy, and come together to say we think that we should put in a ceiling for all narcotic prescribing within the medical group at 90 morphine milligram equivalents. And we also believe that we should not be prescribing methadone because of the highly variable way that it's metabolized for different individuals. So we are putting that policy out, and we have had it approved. It's approved as of October 1st. And in the future, we'll start to look at, through electronic medical records, what the prescribing habits are. Are we prescribing more than 90 morphine equivalents? Are we prescribing methadone? We'll be able to see if that's occurring. We want to give everyone 4 months to work through that, and so we won't start to look at that at all until the 1st of February, when we'll start to kind of look and see where we're at with people. So you have 4 months to work with patients to get them into pain clinic, to get them on weans, and implement this policy. The policy will come out to you by email this week. In addition to that, we want to give you some resources to help you work through this. The first is pharmacy. So if you have a really difficult patient which you do not know what to do with the level of their narcotics, we can give you resources to help with the wean. So you need to let us know, your director, your regional medical director, myself, that you need some help with a patient for a weaning protocol. The other mechanism we want to put in place is education, and Amy can speak to that.
Yeah. Knowledge is power, and I can't tell you how empowered physicians feel when they learn about some of the things that can be done. I mean, I think we all realize this is still probably the most difficult patient population is the chronic pain population. That being said, there's a lot of new information that empowers us to try and improve their quality of life, because a lot of patients in chronic pain don't have that good of quality of life. We're hosting a CME sponsored by SVMG, which is going to be Saturday morning, November 12th at the Renaissance, and you'll all get an email and a flyer about that CME. There's also the availability. I'm available to come meet with individual providers or groups of providers to do an individualized education. At the same time, we can talk through what kind of office processes, what kind of office policies are going to help facilitate you being able to continue caring for this population. And I think the bottom line is the paradigm of pain treatment that we have operated under for the past, really since I've been in practice, is no longer considered safe. It's no longer the standard of care, and it's going to take a lot of innovation and a lot of hard work for us to rework how we treat our patients with chronic pain. And it's my hope that through education and the willingness of providers, that it's going to make care safer for our patients. It actually, one other thing which I mentioned to you, Aaron, is that new doctors working with the residents, they don't want to join a practice that doesn't have a policy because they're so afraid of getting an overwhelming number of pain patients. Just like I'm sure most of you are aware, it's challenging. So I think it helps the practice, it helps the patient, and ultimately, helps our community.
Thank you, Amy. If you have trepidation over this policy, I would highly encourage you to let us know, and we'll have Amy come out and talk with you. She's done some great work with some of our practices already. So takeaways today: you're going to be receiving an email notifying you of the new narcotic policy within the medical group. We'll look to start to monitor that after February 1st of 2017. And we want to help our practices do no harm and make sure that we're providing safe and quality medicine for our providers to give and for our patients to receive. So thank you.